We'll give everyone a few minutes to get situated. Autumn, welcome. And if you're new, save your questions until the end of the presentation. We'll do some learning and then we'll do some practice questions. And then I'd be happy to answer any questions or concerns that you may have. The resources that I use are RxPrep and Pass Naplex Now. Both are excellent resources. It's a very common question, which one is better? That depends on how you do your learning. Both are excellent resources. If you're doing practice questions and you feel that one resource has not prepared you, make sure that you do some more research and supplement that resource as well. Allison, welcome. Suspicious Bunch, welcome. Art, welcome. So, once again, I'm ChicagoDLSinc. We do Naplex and MPJE tutoring. If you have any questions or concerns, feel free to reach out to me via direct message. Sunflower, welcome. All right, so we'll go ahead and get started. Background, TB is short for tuberculosis. The bacteria that causes this is called Mycobacterium tuberculosis. It's spread through air droplets or cough. So exposure to TB can lead to either active TB, which is symptomatic and contagious, or something called latent TB infection. This is also known as dormant. It is asymptomatic. You are infected, but you are not sick. We'll switch from you to the patient. The patient is not contagious. The PPD test will be positive and the chest x-ray will be negative. And in the next couple slides, we'll talk more about that. It can also become an active infection if it was latent before as a result of immunosuppression. We have steroids, disease-modifying anti-rheumatic drugs, HIV, and old age. Now, in bold, only patients with the active disease are contagious. So, if someone comes to an ID clinic and their PPD is positive, but they don't have symptoms, you are okay. Patient with active TB will be sick. You will see it, and we'll discuss the symptoms here. Lexapro, welcome. Mercedes, welcome. And C. Wade. So, who needs the TB skin test? This is going to be close contacts of someone who was diagnosed with TB, active, healthcare workers, people who have symptoms of tuberculosis, and these symptoms are all going to be together. Chronic cough, and it's going to be productive. Productive meaning sputum or mucus. You're going to have fever, weight loss, night sweats, fatigue, hemoptysis, which is coughing up of blood, and then also, so these are all symptoms. The patient will present with all of these. Other uh, other patients that may need a TB skin test is job requirement for screening, decreased immunity conditions such as HIV, or patients that are planning to start the disease modifying drugs for rheumatic diseases. Now, all the drugs that are used to treat TB are bactericidal except for ethambutol. Can anyone tell me in the chat what is the difference between bactericidal and bacteriostatic when it comes to antibiotic mechanism of action? And then the acronym RIPES, RIPES. That's going to stand for rifampin, isoniazid, pyrazinamide, ethambutol, and streptomycin. All right, getting some answers. So, cidal does kill and static stops growth. Very good. Very good, everyone. So, by stopping the growth, the infection dies out. Bactericidal drugs will actively reduce the infection. All right, very good. So now we'll go to the next slide, which is test for diagnosis. On the right side, you'll see an arrow pointing to a pink bacteria, and that is going to be tuberculosis. If you looked at it under a slide, and I'll talk a little more about that. So the TB skin test is also known as TST, and the PPD is purified protein derivative, and this is given intradermal. This test, I'm going to assume most of you have already had one before or seen it administered. I myself have had several. This test is read 48 to 72 hours after it is administered. It becomes positive 2 to 8 weeks after infection with TB, and it can be either latent or active. The chest x-ray assists with locating infected areas of lungs and active TB, or to rule out active TB if the PPD is positive. So let me explain that. You may have a PPD test that's positive. The patient does not have any symptoms. Let's say they're here for job screening, and you'll send for a you'll recommend the patient for a chest x-ray, and if it comes back clear, then they don't have active TB. It may be latent. All right. Positive result. The significance depends on the individual and the size of the skin reaction. What we measure is something called induration, and induration is hardness and redness at the injection site between 2 to 3 days after the injection. I have a picture on the following slide. So 5 millimeters is going to be considered a small reaction, and we only consider this to be positive if they have low immunity, such as HIV or steroid therapy, or at a high risk for TB infection, such as close contacts. 10 millimeters we see in diabetes, chronic kidney disease, and healthcare workers. And this is for healthcare workers, is thought to be due to repeated exposure. And then 15 millimeters or greater is positive for everyone. Now we have TB blood tests. And this is going to be quantiferon gold. And gold in the name, it's considered the gold standard, as well as T-spot. Fun fact, it's about $100 out of pocket if a patient is uninsured. Acid-fast bacilli. So the bacteria that cause tuberculosis, Mycobacterium, is something called acid-fast. What that means is when we stain it, it absorbs the acid, thereby resulting in that pink or reddish color that you see on the picture to the right. So this would be if we culture the sputum or the mucus, and it can take days to weeks. And positive acid-fast bacilli means that TB is active. All right. So on your screen, you'll see left to right the intradermal test with the PPD, and in the middle, you'll see the reading. You can also do it with a regular ruler now that you know 5, 10, and 15 millimeters. And to the right is a positive PPD, the angry pink spot with a pen outline on the forearm. All right. So the next slide is going to talk a little bit about the vaccine. This is called the BCG, Bacillus of Calmette and Guerin. It is a vaccine against tuberculosis and mostly given in countries that have high prevalence. And after you receive this vaccine, you will have a positive PPD, but it may wear off after years, just like any vaccine. So in the picture on the left side, the vial is the BCG, and on the right side, that is the skin marker after you received the vaccine. So for the latent TB infection treatment, And I just want to clarify, if you're looking at the chest x-ray, in latent TB, you will not see any of this. This is for a active TB x-ray. I just ran out of space on the other slides. So if you're looking at this x-ray, just remember this is for active. A latent TB will have a clear chest x-ray with no findings. So for latent, you have a positive PPD, the skin test. Your chest x-ray is negative. There will be no symptoms and the patient is not contagious. Now, by treating latent TB, we can reduce the risk of an active TB infection later by about 90%. The statistic is 1 in 10 patients with latent TB will develop active TB. Just want to say welcome to Deb, and we'll continue. So the drug of choice here is going to be isoniazid. The abbreviation is INH, 300 mg POQD times 9 months. And then we will add vitamin B6 or pyridoxine, 50 mg QD. Can anyone tell me why we need to add vitamin B6 in the chat? An adverse effect of isoniazid, hepatotoxic. You do have to check liver function tests. And if a patient presents with symptoms, stop. Alternatives are going to be rifampin 10 mg per kg up to or 600 milligrams, POQD times 4 months, or isoniazid 900 milligrams plus rifapentine 900 mg PO weekly times 12 weeks, or isoniazid and rifampin QD for 3 months. All right, getting some answers. Yes. So Tara, you are correct. We are decreasing the side effects. And Peacock, you are correct. It decreases peripheral neuropathy. Great. Great job, everyone. So let us continue to the next slide. So now let's break down the medications for TB. We have rifampin with a brand name Rifadin. The hepatotoxicity, so in parentheses, liver function tests, as well as nephrotoxicity. The adverse effects can be fever, rash, flu-like illness, GI upset, thrombocytopenia, for which we would do a CBC. You'll know the patient will notice increased bleeding. Rifampin is an inducer of CYP1A2, 2C9, and 3A4. Can anyone tell me any drug that is metabolized by 2C9? Anyone is acceptable? And while we give everyone a minute on that, continuing, we have decreased efficacy of oral contraceptives and decreased INR with warfarin. So we avoid protease inhibitors. It can increase the risk of hepatotoxicity. And for bodily fluids, it can change the color to red-orange. Patient may notice their contact lenses being discolored. And then we have the dosage. Have to make sure you take it on an empty stomach because the concentration is decreased if taken with food. And then we have capsules, suspension, and IV for formulations. So those of you that answered clopidogrel or Plavix, you are correct. For those of you that answered warfarin, you are also correct. Great job. Great job. All right, next we have rifapentine or rifapentine. Excuse me, brand name is Prifton. This is a long-acting derivative of rifampin. The adverse effects you're going to be looking at are going to be hepatotoxicity as well, thrombocytopenia also, and then hyperuricemia. Rifapentine, the discoloration is going to be orange-brown of the urine, and then, of course, the patient may notice their contact lenses as well. All right. So the next slide is going to be pyrazinamide. This is going to be 15 to 30 mg per kg up to 2,000 milligrams orally once a day. Adverse effects are going to be hepatotoxicity, hyperuricemia, and avoiding in renal dysfunction. Next, we have ethambutol. Brand name is going to be myambutol. Adverse effects are going to be optic neuritis. We're going to test color vision and visual acuity monthly if the dose is greater than 15 mg per day, or if the patient mentions something. Now, ethambutol starts with an E. The adverse effect is optic neuritis, so I. Good way to remember that. Streptomycin. Adverse effects here are going to be nephrotoxicity, ototoxicity, and we're going to avoid combining with other ototoxic or nephrotoxic drugs. It is contraindicated in pregnancy. You have to monitor auditory function, renal function, and electrolytes. And then the dose is going to be 15 mg per kg up to 1 gram IM or IV daily. Okay, so we have other medications for TB. Bedaquiline, brand name is Serturo. The indication here is going to be part of combination therapy for 18 years or older with multi-drug resistant TB. This should be administered by something called DOT, directly observed therapy. Now, if you're not sure what that is, you, as a pharmacist, will dispense the medication, you will watch them take it. That is directly observed therapy. Dosage forms. Sorry, it's not just the pharmacist, it can also take place in the in the medical office. So, dosage form. We have 100 mg tablets. You only use this in combination with at least 3 other drugs. There's also a version of TB called XDR. Can anyone tell me what that is? Once again, XDR. So we use it in combinations. One in weeks 1 to 2, we'll do QD with food. Weeks 3 to 4, we'll lower the dosage to half, and then weeks 3 to 24, sorry, you'll lower the dosage to half 3 times per week with food. Good, resistant. X means it's resistant to all TB medications. You'll also see it in terms of certain sexually transmitted infections, XDR. All right, so caution with bedaquiline, QT prolongation, hepatotoxicity, counsel a patient to avoid alcohol. Now we have some brand names, Rifamate and Rifater. Rifamate is isoniazid and rifampin. Take it daily on an empty stomach. Rifater is isoniazid, rifampin, and pyrazinamide. This dose is weight dependent and take on an empty stomach also. So the preferred regimen to treat TB, for the first 8 weeks, we're going to do the 4 drugs, RIPE, and then after that, for 4.5 months, we'll do isoniazid and rifampin. Why might you ask that we need to do such a long treatment course? Tuberculosis can develop resistance with single medications, and that's why we do more than one drug at a time. All right. So, counseling points and a newer drug. For isoniazid hepatotoxicity, for the rifamycins, which are going to be rifampin and rifabutin, or pyrazinamide, patients should report any nausea or abdominal pain and limit alcohol and acetaminophen. Rifamycins can cause orange discoloration of urine, sweat, and tears, and can permanently stain soft contact lenses. With rifamycins, if a patient complains of small red purple spots on their skin, this may be a sign of purpura and thrombocytopenia. Refer to MD. One of the areas of competency on the Naplex is knowing when a patient comes and asks for a recommendation, how long is too long and when you're supposed to refer. A really good example, we're not talking about HIV today, but if they choose to do the over the counter screening test, can anyone tell me in the chat what a brand name is for the over the counter HIV test? But a patient may come and say, hey, this is positive. What advice are you supposed to give them? And that is follow up with your healthcare professional because you need confirmatory testing. There can be false positives and there can also be negatives. Anyone? And if you're not sure, that's okay. Here is your place for learning. You want to practice here so you get it right on the Naplex. All right, I have one answer. Genesis or quick is correct. Excellent. Great job. So, drug interactions. Rifamycins are inducers and can decrease levothyroxine, phenytoin, warfarin, oral contraceptives of all kinds, and suggest switching to depot or an IUD or adding condoms. Advise adding vitamin B6 for isoniazid. We talked about peripheral neuropathy, very good. And then recommend an antihistamine for mild itchy rash. TB meds can cause itching. So the newer medication is pretomanid or pretomanid. And I always say that we are not being tested on pronunciation, which is a great thing. And this is part of a combo regimen with bedaquiline and linezolid for the treatment of adults with pulmonary extensively drug resistant, there's that XDR, treatment intolerant or non-responsive multi-drug resistant tuberculosis. So, once again, it must be administered only as a part of a regimen with bedaquiline and linezolid, 200 milligrams PO once a day with food. Swallow tablet whole with water for 26 weeks. Now, a patient may not present with non-responsive or XDR. They may have started RIPE or RIPES therapy and become non-compliant or partially compliant, and the bacteria that is causing the infection for them has become resistant. All right. So now I'm going to go back one slide. I have three practice questions. And if you're new today, I'm going to read the question and then you can put the answer in the chat. If you're not sure, you can take a guess, put a question mark by it, or just, or keep it to yourself. But I would recommend attempting it. Once again, this is a place to get it wrong and do your learning. So when you take the Naplex, you get it correct. All right, so practice question one. IL is a 47-year-old male patient recently diagnosed with active tuberculosis, HIV negative. His past medical history is significant for hypertension and hyperlipidemia, for which he takes lisinopril hydrochlorothiazide 20, 12.5 mgs daily, and simvastatin 40 mg daily. To treat his TB, he will initially receive a 4-drug regimen of isoniazid, rifampin, pyrazinamide, and ethambutol. Which of the following patient counseling points would be appropriate for IL regarding this regimen? Select all that apply. So this is a select all that apply question. There can be one correct answer, and all of them can be correct, or anything in between. I always say that RxPrep and Past Naplex now does a really good job of not setting any patterns. You should truly know your information. All right, we'll give everyone a chance to, who would like to answer. Okay, so what we'll do is the correct answers are A and D. So if you chose A and D, very good. Let's talk about why. Active tuberculosis, we treat initially with 4 antibiotics. There also is culture and sensitivity done. And choice A, rifampin, can turn bodily fluids orange, reddish, brown. Now remember, the brownish color is more for rifampin because it is a longer acting derivative. Now, answer D is also correct. Isoniazid has a very high hepatotoxicity risk, and this can be uh, exacerbated or amplified with alcohol. Excuse me. So now some of you chose B, and B is an important counseling point for pyrazinamide. So remember, with the Naplex, all parts of the question have to be correct. So while there is an increased risk of gout attacks due to hyperuricemia, that is due to pyrazinamide, not ethambutol. So take your time and make sure you read each choice of the question. And if you look at choice C, C is for ethambutol, not pyrazinamide, so they just switch the two adverse effects. Now, choice E, rifampin is a potent inducer, and that would decrease simvastatin concentrations and decrease effectiveness. Did anyone have any questions or concerns for practice question 1? Any question, doesn't matter how big, how small. And if you think of one later, I'd be happy to address it later as well. Alrighty. So we'll go on to the next one, and I think I have 3 today. So, a 55-year-old male with a history of atrial fibrillation and congestive heart failure is diagnosed with tuberculosis. His primary provider places him on rifampin, isoniazid, ethambutol, and pyrazinamide. His other medications include Coumadin, Lasix, lisinopril, and Toprol. Given his isoniazid use, which black box warning exists for this medication? Choice A, kidney failure. Choice B, hepatitis. Choice C, thrombocytopenia. And choice D, increased risk of pancreatic cancer. Once again, we'll give everyone a minute to process and make their best choice. All right. So the answer for this one is going to be B, hepatitis. So everyone who chose B, great job. And if you put a question mark by it, make sure you go back and review. So this one, just a second, going to get the explanation. All right, so isoniazid is notoriously known for hepatitis. It can be fatal sometimes. Um, Other medications that we worry about for nephrotoxicity are going to be some of the earlier ones that we talked about, and thrombocytopenia can present with the purple red spots, and then the increased risk of pancreatic cancer is an outlier. There is an increased risk of, yeah, pancreatic cancer is an outlier. All right, very good. Any questions or concerns for practice question two? And then we'll go on to practice question three. Once again, if you think of one later, just let me know. A 77-year-old male with a history of multiple DVTs is currently receiving warfarin therapy. He is diagnosed with osteomyelitis and treatment with rifampin is initiated. What will likely happen to INR when rifampin is discontinued? All right, very good. Give everyone a chance to answer. All right, getting a mixture of answers. And so once again, it says what will likely happen to INR when rifampin is discontinued. So the correct answer is going to be A. INR will go up. And let's talk about why. Several of you chose B. And Charmut, great job. Uh, Rifampin is an enzyme inducer, and it will cause coumadin or INR to go down. Once we stop it, because metabolism is no longer induced, INRs will likely increase. Yes, or we can change warfarin to an alternate therapy. All right, very good. So that was practice question three. Does anyone have any questions or concerns for any of the practice questions that we did? Tuberculosis in general, today's presentation, the Naplex, the MPJE, anything I can help with, I'd be happy to answer for you. While you're thinking of any, shout out to Suspicious Bunch and Pharma Turtles for setting all this up. There are excellent notes and resources in the resources section, and you're welcome. You're welcome very much. So once again, if you're interested in one-on-one sessions, we can do as little or as much as you need. Or if you're interested in group sessions for particular topics, please reach out via DM. You're welcome, everyone. Happy to be here. Happy to help. All right. Everyone, good luck to you on your preparation. And uh, uh, Dave or Dev, you'll see the recording will be posted later today, and you'll be able to see it online. All right, everyone, good luck on your preparation.